How exciting that we're in this virtual world, and I'd like to welcome you all to week one of the four-part series looking at allogeneic transplant webinars. So together with my colleagues, Linda Saunders, Jane Anderson and Linda Thomsett, I'd like to welcome our guest speakers, a consumer and donor himself, Mr. Leon Parmenter, Dr. Hung Yang, and Miss Taylor Jervois and Miss Annette Barnes, who are going to be sharing their knowledge and expertise and experiences in the world of pre-transplant. But before we start, I'd like to give an acknowledgement to country. The Leukaemia Foundation acknowledges the traditional owners of this country throughout Australia and recognises their continuing connection to land, sea and community. We pay our respects to their elders past, present and emerging. Now, some of you may ask, why are we holding this seminar series? Well, we understand that there are many unique and complex aspects of the allogeneic transplant experience, one that only those of you who have experienced it can truly understand. So what we hope to achieve with this webinar in this four-part series is to capture a different focus from different perspectives. So today, in week one, we're going to be looking at preparing for allogeneic transplant, looking at the pre-transplant workup and donor experience. We will hear both personal and professional perspectives, or learn all about what's involved in the pre-transplant workup, and then we'll be offering a group discussion where we'll be able to, share personal experiences and learn from from one another. So it gives me great pleasure to welcome Leon Parmenter here this morning. He was a donor for his brother who will be speaking and sharing his experiences in week four. Leon is a pastry cook by trade. He now, and for the last 15 years, has been working at Marrow at George Western Foods. Leon is married with three girls, 19, 13 and 9. He loves fishing, going Stradbroke Island camping, and is someone who has always tries to have a positive outlook. So I'll hand the state over to you, Leon, to share your experiences as a donor for your brother, Clinton.
Thanks, Marianne. So my name's Leon Parmenter. I was a donor for my brother Clinton, who is 5 years post 5 years post transplant. So very positive news. I just wanted to come on here today, obviously, to share my insights and thoughts. And any questions anyone does have, please go to the chat line, and I can answer as best and close as possible. Now, I have been asked a few questions, and I'd like to answer them. I'll go by stage. So, obviously, the first question: when you were asked to be considered as a donor, what were your initial thoughts? And my first thoughts were happy to help. What's involved? Everyone around me had also offered themselves. Then it was, personally, I hate needles. I didn't even know if I was a match at this stage, but once explained the process and what it meant to my brother's life, that went out of my mind, basically. Little did I know the chances of me being a match was even close, was very low. So very, very happy to sort of obviously find out more, which is probably where a lot of you are at. The donor process, this was explained to me, was it explained to me well, and did I feel, and how to feel about the process? Again, at first, a lot to take in, but once I knew I was a perfect match and my brother had a chance to live, it was a pretty much a no-brainer for myself. It was so professionally well explained, and any concerns or questions I had was repeatedly, reinforced to me, and I felt really comfortable and no pressure. Just made me feel very comfortable. I was doing an awesome thing, and not every day you can save a life. So those sort of positive thoughts and outcome yeah, at the end was very good. Physically, was the donor experience, what was it like? Pretty much how it was explained to me. Once the injections had started, and that my wife would actually inject to me at home, I would feel some tiredness. Best way to describe it was like an older person, I suppose. So that was just the cells increasing, producing what I'd like to say are quality cells. My brother and I have a bit of a chuckle about that all the time. And yeah, having that as a running joke pretty much weekly. It's amazing how they can pull out 21,000 better quality cells from 100,000 cells to go into my brother's body. And yeah, it's very well done. Emotionally, when Clinton, my brother, received the cells, what was my thoughts and what went through my mind? So first thing that went through my mind was, let's hope this works. I don't want to let him down. If this doesn't work, this is his last chance. Those sort of things sort of run through my mind. I was up at the hospital that day when he had the cells, the transplant. I went home after he was injected and thought about the process. Had a bit of a cry because it was obviously personal to me. And just waiting for the news that something good was going to happen. All the GVHD, the graft versus host disease, which you hear a lot about, things that could go wrong. I tried staying positive for his sake, and I may have even had a quiet little prayer or two. So yeah, just some positive thoughts from my mind. On reflection, what has been the donor meant for you? In the words of the doctor, he is a miracle. I know the chances of helping someone in this day and age is pretty slim, so it means so much to give my brother his life, an extension more to his life. For once in my life, I could do something for someone else, and it obviously meant the world to my brother, and yeah, sort of making that feeling. It's very hard to explain the feeling, but it's a good feeling. I can assure you that, and I certainly wouldn't hesitate to move forward in being a donor. It's very uninvasive process. Needles is probably the hardest thing that you come against, and the staff are just amazing. Doctors, nurses, everyone is amazing as part of the process, and you're never left without any help or and that. And yeah, look, I just encourage anyone out there to, if they are thinking about doing it and want to donate, I could not recommend it higher. And I hope anything that I can do here today helps you become a donor. It's for a great cause. So I'll hand back to you, Marianne.
Thanks, Leon. You know, certainly with what you've shared, it's an emotional time. It's a time when you are placed looking at many things racing through your head. But I loved how you've focused on maintaining a positive attitude and recognizing that the gift that you were able to give Clinton for his, you know, to move forward in embracing life, I think has been exactly that, just a gift, and you have been a participant in that journey. So congratulations, it's a big step. You've embraced that, and thank you for coming in here in this virtual room and sharing that experience with us. We really value that you've spent the time. Thank you.
Thanks for the opportunity.
Our next speaker here this morning, looking at transplants, we welcome Dr. Hung Yang. Dr. Hung Yang is the Medical Director of the Australian Bone Marrow Donor Registry. He also works at the Australian Red Cross Lifeblood as their blood and marrow safety analyst. Dr. Yang's particular area of interest is in the assessment and testing of voluntary blood and marrow donors, and he currently chairs the Donor Suitability Working Group of the World Marrow Donor Association, which is the WMDA. So welcome, Dr. Hung Yang. We value that you've been giving us the opportunity to spend some time here with us this morning. So I'll hand the microphone over to you.
There are a sequence of steps that if you're chosen as a match donor, so obviously you first have to join the registry either through lifeblood, which involves a blood donation, or via the Strength to Give website. And then you may remain on the registry, well, for quite a long time. I've been on the registry myself as a donor for well over 20 years, and I've sadly not been matched to anyone, although I have been matched to people requiring matched platelets on the lifeblood side. Now, if you are ever identified as a match for someone, what a mandatory step that has to occur first is that we have to verify that you have the correct typing, because it may be some years, as I said before, you get matched to someone. And even if it is only a year or two, the progression of science in this field is so rapid that it can be difficult to determine a full match based on old typing, even if it's only 2 or 3 years out of date. And it's also a mandatory step to just verify that we've got the right donor for that match to that patient. And then once you go through that process, there is the opportunity taken of a questionnaire assessment, and if you're chosen as the donor, you go through workup as Leon described, and then the donation process, which I'll describe further in later slides. But after the donation process, then you go through a 10-year process of follow-up. So joining the registry, as I said, is either through the website or through Lifeblood. The important thing about joining the registry is that we need to determine your HLA tissue type, and this is an almost unique signature, if you like, on your white blood cells. And you know, it's certainly not unusual for that signature to be shared with only or far less than 1 in a million people. We do get your blood group when you register, and we also check one infectious disease marker, which is the CMV, and that's a pretty common infection in the community. It's a glandular fever type illness that can have a big effect on transplants. And that's the only mandatory sort of infectious disease that we screen for. And of course, an important part of this is that we have to get your informed consent for the process. Now, if you do match someone on the registry, then this mandatory step is called verification typing. Verifies that you are in fact the correct donor that was matched to the patient, and that you have up-to-date HLA typing. And that process occurs by sending a sample to the transplant centre, that is to the patient's lab, for HLA typing, and ensures that there's no disagreement between the transplant centre and the donor registry, which may of course be in a completely different country, on what the HLA typing of the donor actually is, and whether there is actually a match. The opportunity is taken at this point to do some blood tests for more infectious diseases, HIV, hepatitis B, Hep C, those sorts of things, and then run through a standard questionnaire to assess their general medical condition. And ideally, because there are over 35 million registered donors in the world, even at the odds of 1 in a million, you could actually find more than one match on the worldwide registry. And so ideally, a transplant centre would run more than one donor through this process at the same time and choose the best one for workup. And even, again, ideally, if there is more than one suitable donor, then the second best may be asked to be a backup donor in case something happens to the first one. So if you are then chosen as the best donor, or even the second best donor, you will be asked to do a workup assessment, and that involves an appointment at the collection hospital for a complete medical assessment. And that involves not just the questionnaire again, but an actual physical examination. There's all sorts of tests like blood testing, chest x-ray, ECG, and that sort of thing. And there is a final, of course, consent process where we need the donor's informed consent to commit to the procedure, because as you are probably all aware, that once the patient starts their patient conditioning, their bone marrow preparation for transplant, then that is a little bit of a, not so much a point of no return, but it is certainly a difficult point where you will be subjected to bone marrow poisoning, and will then be expecting a transplant to occur. So there are two types of donation that we can use two processes that we can use to collect the bone marrow cells these days. I think Leon described the other process, which is peripheral blood stem cell collection, but the traditional process that is still used in about 10% of cases is called a bone marrow harvest, and that's where the bone marrow cells are taken directly out of the a donor's hip bones. And that type of collection may be preferred in certain conditions, particularly where the patient is a child or has severe aplastic anemia. So as you can imagine, this is done under general anaesthetic, so it requires an anaesthetist assessment. Therefore, of course, you're asleep when the bone marrow cells are extracted, and this occurs as a day procedure in a collection hospital. All collection hospitals in Australia are actually major transplant hospitals. And then what Leon was describing with his experience was the peripheral blood stem cell collection, which is much easier for both, I guess, donor and collection centre, and therefore it's pretty much done in 90% of cases. And what you need is a cell separator machine, which in medical Greek is called an apheresis machine. And this is very similar to what we use for many types of blood donations and for plasma exchange. But the catch is that there aren't actually normally any bone marrow cells in the peripheral blood or peripheral bloodstream. And so what you have to do is that you have to give the donor a medication to push stem cells into the bloodstream. And there are a number of medications that can do this by increasing your white blood cell count. In the olden days, we used to use corticosteroids, but now we have a much better medication called G-CSF, which is an inflammatory mediator, and so it helps you fight infection by pushing white cells out into the bloodstream. And along with that, there are some sort of a lot of inflammatory chemicals which can cause a flu type sort of side effects like aching and fatigue. But again, that's should be fairly minor and able to be controlled with rest and painkillers. So you just have to start these G-CSF injections 4 days before the donation. It does take a few hours to collect for the apheresis collection machine to collect the white cells and extract them, separate them out from the other cells. And that, of course, is also done as a day procedure in a collection hospital. So once you've done that, you generally will be going home either that day for PBSC or perhaps even the following day for a bone marrow, and then you're followed up by ABMDR at least within 72 hours after your collection, and then weekly, and until they are fully recovered. At the 3-month mark, we do routine blood tests to check your recovery, and then we follow you up at least every year for at least 10 years to check for long-term adverse effects. So that's all the slides I've got in my talk. I'm very happy to answer any other questions that people might have coming out of those slides or about the process in general. And thanks for listening.
Thank you, Dr. Yang. Such valuable information in a very sequenced way of events. So following from Leon's presentation, it was a lovely capture of the medical side of how we collect cells and the different avenues and the different processes and procedures that a donor undergoes. I'm just going to hand it over to Linda Saunders for the Q&A. So Linda, do you have any questions that you'd like to ask Dr. Yang?
Thanks, Marianne, and thank you, Dr. Yang, again, for that really nice and clear summary of the donor experience from the medical side of things, which complemented lovely Leon's personal account. Just encouraging the audience to place your questions in the chat. We do have a few questions that we have received prior to the event. Dr. Yang, you did mention earlier that obviously as a donor, they are unable to know who their donation goes to. It is certainly a question that a lot of, certainly us blood cancer support coordinators at the Leukaemia Foundation get asked is there any way that we, perhaps if we can't find out, is there ways that we can just understand, generally who our donation may have gone to or which country that donation may have gone to?
Yes. So generally, we will tell ABMDR donors whether their patient is overseas or in Australia, whether their patient is an adult or a child, and I think generally the gender of the adult or child, and they're also allowed to, after a certain waiting period, I can't remember exactly what that is, Taylor might be able to remember, there is anonymous communication allowed between donor and patient. And then after a 2-year period, then if there is independent, requests from active requests from both donor and patient sides, we will allow actually non-anonymous contact after 2 years.
Great. So is that something that is actively facilitated, obviously with the initiation by the donor and the recipient, that is something that could be actively initiated by the ABMDR or facilitated?
That's
sorry,
right.
There is a better word.
Yes, we have a process. Yes.
Fabulous. It's good for us to know that too, in terms of
is.
talking to potential donors about, because obviously there's value in wanting to be able to donate to know where that donation ends up, and I think that's something that encourages people to donate if they are aware and can find out that really important information.
And also for the patient, that perspective of wanting to thank for new life and being able to move forward. It's an opportunity for them to personally thank that person who has taken time to donate their cells. So that is good to know. Thank you.
We actually noticed your first slide, Dr. Yang, has all these beautiful and diverse hands. We wanted to ask some questions around mixed cultural heritage and some of the complexities that are faced for people who have diverse cultural backgrounds. So perhaps I'll ask that question first, and then there is a secondary question after that that's sort of come from that visual of your first slide.
Sure. So first of all, I guess I can talk about your chances of finding a match, if you're a patient, your chances of finding a match on the worldwide registry, depending on your ethnic background. So basically, if you have European ethnicity, fortunately for you, around about 85% of the 35 million plus donors registered around the world are of European ethnicity. So your chances of finding a match are extremely good. They're well over 90%. That's if you don't have a match, of course, among your siblings. So that decreases, and that 80 to 85% European ethnic background is also reflective of what we have in ABMDR as well, because that is reflective of the blood service lifeblood, where we have overwhelmingly European ethnicity represented in the donor population. So the news is not so good if you do not have European ethnicity. I think if you don't have European ethnicity, I think Middle Eastern would be next best. Asian, not so good, and African would be the least represented on the worldwide registry, and particularly in Australia, as you can imagine. So that's the odds if you have that sort of ethnic background. If you then have a mixed ethnic background, it can be even more difficult. So I think that, remembering that your HLA, even though there's millions and millions, probably billions of potential combinations of HLA tissue types, you inherit fully half in one set from each patient, from each parent. And so basically, if you have mixed ethnic background, you could have one haplotype or HLA haplotype that is common in the European population and one that is common in, say, the Asian population. And so if that Asian haplotype is not common in Europe, then you may have that difficulty, just as if you had completely Asian heritage.
Okay. We do have a question in the chat around are all the donor stem cells used in the transplant? And if
Yes.
not, what happens to any unused stem cells? So there's three elements to this question.
Yep.
And could any unused stem cells be reused in the same recipient?
Yep. So basically, yes, no.
The short answer.
So if you've got an adult patient, the chances are that yes, all your cells are going to be used. But of course, if you have a pediatric patient who is much smaller than you are, then and particularly if you're not donating bone marrow for them, if you're donating PBSC like Leon did, it's a much bigger dose that you get from PBSC than from bone marrow. And so quite often, in fact, quite commonly, I can tell you that there are going to be leftovers when the patient is very small, and the transplant centre can freeze those cells and save them for later, just in case. And I think Taylor might have more to say about that, but the third question about can we use it for someone else? No, we can't. There is an absolute regulatory ban on that. Although there have been discussions internationally through the WMDA, the World Marrow Donor Association, about getting donor consent at right from the outset to do that potentially.
Okay, thank you. I hope that answers the audience, that participant's question. Finally, I just wanted to get you to comment a little bit about the impact of COVID on donation. We've certainly heard at the Leukaemia Foundation, what some of the implications for recipients.
Yes.
in relation to COVID and access to donations. Can you just, comment about that, and particularly why it's had such an impact in Australia
Mm.
in terms of
Okay.
our own donation rates?
Yeah, okay. So look, this is a huge question, and I guess you'll probably have to stop me at some point. But first of all, the first question that people asked right at the beginning, and seemingly the most important, but in actual fact, one of the least important, is the question of whether you can transmit COVID-19 through a transplant. And the answer appears to be no, just as we knew from the first 6 human coronaviruses, i.e. the 4 that caused common colds and SARS-1 and MERS, that none of them seem to be transmitted through either blood transfusion or bone marrow transplant. So there's no risk there.
Mm-hmm.
However, it has just the pandemic itself has just had such a massive impact on the whole process of getting donors, collecting donors, matching donors, and getting them transplanted into patients. Because I think the big issue is transport, because we're getting close to 90% of our unrelated donations from overseas. That has been a massive problem. And we've had to eventually, back in March last year, we were trying to race and get, things across the borders, and they were closing before our eyes. And what we eventually have had to do now is that we've had to say, well, look, we can't rely on flights. We can't do couriers. And we can't even rely on flights, even if we had the couriers, because there's all the flights are being cancelled. So what we're going to do is going to freeze the donations, which is a massive change in the whole process, because it means, on the one hand, you don't have to condition your patient in advance, but on the other hand, you have to find somewhere to freeze, because not every hospital, very, very few hospitals can do the freezing process. You have to find somewhere to freeze it. You have to find some way to get the frozen product to cross borders, and then you have to thaw them. And when you thaw them, sometimes there's a disagreement as to how much is left. So it's been a real problem, and of course it's also forced us to get involved in a lot of related transplants as well, because a lot of related donors from who live in a different country can't get to Australia anymore, and we're having to use the unrelated donor processes and channels to collect them overseas through unrelated registries, which is a massive, massive workload. So I think we haven't really seen too much effect of donors being reluctant to go out into the world, into the risk of the pandemic and donate. It's more that, when there are lockdowns and travel restrictions, they're having to think about going into a hot zone and going back and being quarantined for 14 days. There's all those sorts of issues. I don't think that people are concerned about the COVID so much as the restrictions.
The actual logistics of how to go about doing it.
Yes.
Yeah. Lovely. Well, we really appreciate your time, Dr. Yang, for coming along and sharing your knowledge. And we certainly hope that this opens up a conversation, I guess, for people within their families and their extended networks around donation, and really how simple the process is, particularly at the, to register and to jump on board as a potential donor. So thank you so much for your time today.
I'd like to next welcome our next guest speaker, so Miss Taylor Jervois. Taylor is a clinical nurse and bone marrow transplant coordinator at the Royal Brisbane and Women's Hospital. She's been in this role for the last 3 years. She coordinates patient care for both autologous and allogeneic bone marrow transplant patients. Prior to her role there at the Royal Brisbane and Women's Hospital, Taylor worked in the haematology transplant medical oncology ward at Wollongong Hospital. She and her colleague Annette Barnes, who is also was in the role of a bone marrow transplant clinical nurse consultant at the Royal Brisbane and Women's Hospital for the last 11 years. Annette is online, however, Taylor is going to be taking the reins for this session. So I'll hand the microphone over to you, Taylor, and I thank you for joining us here today.
So today I'll be talking about the pre-transplant workup and the differing parts within that. I do touch basically on the donor part, but we can skip over a fair bit of it because Dr. Yang's already answered all of that for us. So yes, Annette's meant to join me, but I'll try and do my best today. So I'll briefly go through the following. So a little bit on tissue typing, like Hung's already spoken about, donor options, the donor workup, and then following that, the patient process, the patient workup, the role of being the carer, support, and how you can help. So here at Royal Brisbane, we have 3 coordinators, and we have BMT donor coordinators, and we also have those looking after the patients. So we have our donor coordinator looks after related donors, any autologous mobilization, so those collecting their own cells. And then we also are an ABMDR collection centre. And then my role normally is coordinating the allogeneic and autologous recipients. So about tissue typing, it's a blood test that we start, as Hong has already touched on, allows us to identify what and if of a degree you are matched to firstly to your relative. We start the tissue typing for the patient at the start of their treatment. And in this first instance, we look at any siblings if they are available and if they're happy to be tested. There may be a need to tissue type other immediate relatives, such as your parents or children, if they are of an appropriate age. However, this doesn't usually occur initially. Common question that we get is, what if a relative or sibling isn't an option for me? For whatever reason this may be, it is a very common question that we get. There have absolutely been patients in this situation or something similar. And in this case, we start, if you are an Australian resident with a Medicare card, we're able to start that unrelated donor search through the ABMDR. So as Hung said, we search for an Australian donor on the Australian Registry. And then if nothing is able to be identified there, we do look at the international registries in the attempt to look for that fully matched donor. After we search both those registries and relatives, we can have one of the following donors. So the type of donors that we use here at Royal Brisbane, so we can use a fully matched sibling, which is a 10 out of 10. A fully matched voluntary unrelated donor, which is our VUDs, a haploidentical related donor, which is usually a 5 out of 10 match, or a mismatch unrelated donor as well. As Wung said, some patients may have multiple donors, and unfortunately there are some people who don't have a suitable donor. Your doctor and medical team here will advise you of what your donor options you have and which is appropriate to be used for your transplant. We are the only transplant centre in Queensland that transplants patients using both related donors and the unrelated donors via ABMDR. Touching back on what you spoke about, Linda, in the COVID-19 pandemic, we have seen an increase of use for haploidentical donors. This we saw probably mid last year, the more use of the haploidentical donors as there was, a bit of a halt and a bit of impact with the COVID-19 across the world. The donor selection involves a lot of variables to be considered. Your doctor will inform you of these and what options are available if you being the patient. Nowadays, we are able to adapt and amend our protocols to safely cater for patients that don't have that fully matched donor. Moving through to our donor workup. So briefly, what Hung's already spoken about, if you are to be a donor for stem cells or bone marrow, you undertake a medical assessment, or as we call it, a workup. This workup may differ from site to site. However, under our accreditation, our donors undertake the following, and that's within a 30-day time frame of the donation. So we do have that education, a questionnaire on your medical health history, chest x-ray, ECG, blood tests, and finally an assessment by our nurse practitioner or one of our haematologists. So as mentioned, we do have both roles of the donor coordinator and then those looking after the patient, such as myself, and we keep those separate just to keep confidentiality for both the donor and the patient. Whether you're a related donor or not, everything's kept quite confidential and quite separate here. So that leads us to our patient assessment and process. So every centre is slightly different with their timelines, testing and their processes. However, I'll walk you through what our general process is. So you are referred by your haematologist to be seen by one of our transplant physicians at our hospital. You are then accepted for transplant. BMT planning begins, and that can be anywhere from 4 to 6 weeks out from transplant. You undergo your own workup, which I'll go through. And then after that, all being well, the patient commences conditioning, and that can be a combination of chemotherapy and or radiation. And what that does is gets you ready to then have the new cells transplanted to you. So as for our patient workup, before you can safely proceed to transplant, we want to ensure you're well informed, your organ function is sufficient, your disease is under control, and yourself, your carer, support team feel comfortable in the process to come. In doing so, we plan your workup, of which has to occur, again, different in every centre, but here it's within 30 days of you receiving your new cells. The workup itself is roughly 5 working days of medical assessments, as well as information and education of your upcoming BMT. So these include a variation of, so on the left we've got your education part, so you have education with myself and we go through the ins and outs of transplant, what to expect on what day leading up to getting those new cells, and then a bit about your inpatient stay and then what happens after. You see our pharmacist who goes through all of your medications, you see and are assessed by our dietitian, social work and welfare teams, and then the medical assessment. You have, as for tests, you have a heart function test and lung function test just to see those capacities and how well they're working. You have an ECG and a chest x-ray, a disease reassessment, blood tests, a dental check and a skin check. So they're all performed here at Royal Brisbane. We do those within the 30-day time period. Sometimes there is delays, and we've definitely had delays over the past year, whether it be donors, whether it be patients, and it's just things that need to be repeated. Although you may have had some information, being the patient, regarding transplant from your doctor, friends, or online groups, fellow families you've met, this week of appointments can be tiring. It's lots of information. You'll hear the same things a fair few times. We try to give it to you written and also verbally as well, because it is a lot to take in. There will probably be some angst and some nerves about this week of appointments and perhaps the transplant, which is totally understandable. Normally, and especially in a non-COVID world, we love you to bring your carer or family member to these appointments, and especially for the information sessions with us. Nice to have that extra set of ears. They pick up things that you don't. However, in lockdown world, we have to kind of adapt all of that. So we have been FaceTiming, calling those relatives if they aren't able to be in the hospital with the patient or their relative during that time and during that week of appointments. It may not seem the same thing, and you may be worried about, you know, are they going to take it all in, or are they okay? You know, like I said, we'll send as much information as we can and go through it all with you at any time, being that care and support group. So, like I said, we walk you through what's going to happen day by day before the transplant, the chemo part, what you can expect to happen afterwards. Whilst we tell you common things you may experience and side effects, everybody goes through it differently, so not every single thing can be mentioned. A requirement, and you know, especially here at Royal Brisbane, and again may differ from centre to centre, that you must live and stay close to Brisbane for no less than a 100-day period during your transplant. So the transplant day being day 0, and for at least 100 days after that, and that's as per our requirements here. We have a great team of welfare workers and our Leukaemia Foundation who help and assist with those who are in this category and need assistance with temporary and local accommodation. With it being a requirement, there's multiple support for you as the patient and or the care team inside and outside the hospital during this time. You'll be supported throughout the workup and whilst you're in hospital by us and every MD team member that you meet that week. We try to demystify the angst by introducing you to some of those soon-to-be familiar faces. And it's essential to tell you all of the things that we can to prepare you on what's to come. Whilst you're an inpatient support-wise, you've got the nurses, doctors, the MDT team, plus all of those that you had before. So Leukaemia Foundation, our welfare girls, and us as coordinators. Before being discharged from here at Royal Brisbane, you'll meet one of our nurses who are in contact about post-transplant and that follow-up afterwards as well. The other thing about being the carer is you don't have to be a nurse, you don't have to be anyone medical, you've just got to be, you know, that support person for whoever it is that you're caring for during that post-transplant time. You don't need to do anything special, it's just helping with those simple things. So your recovery, social, psychosocial, helping with meals, helping with going grocery shopping. We want to keep our patients away from those grocery stores as much as we can. And also there to advocate. So if there's anything to be told, if there's any questions to be asked, you know, you can be the one on the end of the phone calling us and asking those questions afterwards. So again, support, and that's there all throughout. You know, we still get phone calls from people that are 6 months post-transplant, even people that haven't even got to our books yet and haven't had their transplant planned. We're always there to have that conversation and just help in whatever way that we can or offer what support there is surrounding. And I guess one of the main things that we get asked as a transplant centre, and we have families come to our door saying, what can I do to, you know, help out or be a match? Can I donate for them? And if you aren't that direct sibling, like I said, most not initially, but we would again encourage them to be either a blood donor or go on the Australian Bone Marrow Donor Registry. I was talking to a patient yesterday, and advice that they would give would be it's a day at a time, you know, anything through the transplant workup and through the whole transplant process. It's take each day at a time. Yes, everyone experiences it differently and you can't predict everything that's going to happen. We can inform you as well as we can, but just one day at a time. And it's great to have that support around you, family, friends, and then, like I said, within the hospital and without. And that's me.
Thank you, Taylor. I think that was a lovely, you know, a lovely finish of the support that's provided in that transplant journey. We value also that opportunity that you and Annette have put together those lovely slides, and certainly supported what Dr. Hung Yang has shared in his very descriptive explanation of what's involved in transplant. So thank you, Taylor. I think that that was really well done. Certainly Oh, I'm sure there's some questions that are needing to be answered, so I'll hand it over to Linda to ask the questions from the chat, as well as some questions that came in to us before this webinar was aired. Over to you, Linda.
Thanks, Marianne, and thank you, Taylor. From the chat, we do have a specific question around what happens if you don't have a carer for those 100 days? One, have you ever faced that scenario before, and what have been some of the options for someone in this position?
Yes, definitely something that we've had before. Unfortunately, here at Royal Brisbane, you aren't able to have a transplant without a carer for those 100 days. Even though you are in hospital for that acute period where you can become unwell, it is essential. You can still become, unwell and need to come back for appointments and may not have that energy to do your normal stuff like your cooking and your cleaning. So here it is essential. You need to have one. There have been times where transplants have been delayed until that carer has been found.
Mm-hmm.
And that's just purely for patient safety.
Yep. Thank you.
I might just add there,
Mm.
Linda, from a blood cancer support perspective and a Leukaemia Foundation perspective, we have worked alongside Taylor and Annette. There have been a couple of identified patients without carers, and together with those families we've tried to look at a roster system with different available friends, family, trying to work with their network of people to see if there was anything that could be achievable in looking at that 100 days and how that would be managed, recognizing that the initial 15 to 20 are as an inpatient, so diffusing that enormity of it's 100 days and recognizing that it can be broken down and what is achievable with your network of people who are in your life. So they're conversations that you can have with your blood cancer support coordinator to help you try and identify what can be done in that space.
Yeah. And I would concur with what Marianne has said. It doesn't have to be to that one person providing the care. It might be multiple people involved in your support and care through that time. So for many people, they don't have just one person who can, commit weeks or months to that role, but it's a sharing of the responsibility. And as Taylor mentioned, it might be about moving the time of the transplant to a point where that carer is able to participate in that person's post-transplant care. So whilst, obviously someone does need to have that support around them, it's a full assessment that needs to happen as part of that, looking at the care and the after transplant care that's required. We do have some other questions, but I am mindful that Annette also would like to comment on that particular question.
Thanks, Linda. So it's just really just to reinforce what you both, you and Marianne, have said, is that yes, we have had those patients previously that haven't had one distinct carer, one family member or one friend, but yeah, absolutely using a roster system. We had one patient many years ago now, he put out sort of an email amongst a group, and he was able to have a team of people that tagged in and out to provide that support role. So it's difficult sometimes. I know we have a lot of patients that find it difficult to ask for help, and that can be something that a lot of people aren't used to, but it can be done. So asking for help is the important thing, and of course just talking with your doctor and talking with your transplant coordinators about it, and also, as Marianne said, they have been an invaluable link for a lot of our patients over the years as well. So
yeah, thanks,
It
Annette.
seems to be more common people having a group of carers rather than just one, because it is obviously hard to get time off work and things like that. So it seems to be more common and seems to work really well.
Yeah, for sure. The makeup of the traditional family doesn't exist anymore. We're such a diverse bunch now. So
Absolutely.
and people live, you know, so far away from one another now. So it is about looking at all the possible options to try and make this happen for the recipient. And thanks, Annette, I think, for really highlighting that the challenge of asking for help. It can be a really, really tricky thing to do. Often people find that challenging at the best of times. And that's certainly where we as the Leukaemia Foundation can also step in to help support people in working through some of those challenges. So please reach out to LF in those scenarios. We do have a couple more questions, and we also have a question that relates back to our first speaker, Dr. Yang, around, and I'm just going to open the question again. Sorry, give me a moment. So thanks, Dr. Yang, for staying on the line as well. An audience question around are those potential long-term effects? So you referenced in your presentation to some of those. I think you follow up at 72 hours, 3 months, or weekly, and then 3 months, and then up to 10 years after a donation. So in the context of that, are those potential long-term effects due to the injections the donor receives? I'm going to take you off mute. Thank you.
Yeah, so that's a great question. So with that 10-year sort of mandatory follow-up, that's an international requirement. So we have been able to get quite a lot of long-term follow-up data on donors, particularly PBSC donors getting the GCSF, and it looks pretty clear that there's no long-term side effects whatsoever in terms of, you know, affecting your ability to make blood cells or your immune system, or you know, any risk of blood cancer or other blood diseases in the long term. However, that's not to say that there isn't any sort of effect in terms of how well you respond to the GCSF. Yeah, we do find that the second time, if you're asked to do a second donation, you don't tend to respond quite as well. And so that's one reason that we still have a limit of 2 PBSC donations per lifetime, and that includes for any ABMDR donor, and that includes any sibling donations that you might have done before joining the registry. But it is very, very safe in the long term. I think that's a very, very good question, because we've got a lot of data from that follow-up.
Great, thank you for that response. I hope that that clarified that question for the audience member. I am just checking the chat. There are a couple of other questions, Taylor, for you or Annette. Can you please clarify how long the acute period stay in hospital is?
Yeah, so that's different for everybody. And I guess it depends what type of transplant you have, whether you're having that fully matched donor or that haploidentical donor. But usually we say around 3 to 4 weeks, but it could be 4 to 5, 5 to 6, depends. But usually it's a minimum of that 3 to 4 week inpatient stay.
Okay. And we certainly do recognise that, like you said, Taylor, there is variation in that length of time, and there's variation. I think you were referencing in your talk around between each of the centres. From state to state, there is slight variation in process, but lots of commonalities as well. So while you were referencing to the Brisbane experience, really very similar to certainly the other major centres who deliver allo transplants as well. So one final question to you, Taylor and Annette. And one of the things that often our consumers ask is, what can we be doing to prepare ourselves for transplant in a period of time where there's often a lot of things that are out of one's control and in the control or in the hands of the treating teams and the transplant team. What, as recipients or as family members, can they be doing to put themselves in the best position for transplant?
So, yeah, you go, Nettie.
I think that preparation is key. It's difficult times. Sometimes people are going into transplant straight off the back of their chemotherapy, their induction chemotherapy and consolidation. So they've, had, they're quite fatigued already from the chemo that they've been through. And then they're moving through this transplant workup and progressing into this transplant with more chemo plus minus radiation. So one thing that we see is always performance status. So that is something that's part of an assessment and something that you can be working on through your chemo and as you move into the transplant and through the transplanters also. And that's as simple as walking, walking around wards where you may be. That's really important just to keep that movement. That's good in so many different aspects, not only for your circulation, not only for your breathing, but also, as we say, we always, in our location at the Royal Brisbane, is where all of our patients walk past each day, and we love seeing them, checking in, having a little chat with them. So it's good to for them to get out of their rooms and have that little chat and see what's going on in the environment around them. Now, there are also caveats to that. Sometimes that can happen if there's, especially with COVID things and other infections going on. So, you would be advised if there's limitations on your mobility around the ward environment where you are. So definitely moving is important. Some people bring in some light weights or the stretch bands and that to use if they can, but you've just got to be mindful around blood counts and things as you move through that. Movement is important. Your eating, that's all important. Once again, that's a challenge as people are moving through chemo. They don't have great appetites, taste buds may be off, but trying to build that, putting that weight on and building themselves up as they come into transplant, because there can be, loss of appetite through that transplant period. So having a little bit of extra there is always handy, and that gives you that little bit of reserve. I'll always say to our patients, we are not a weight loss program. We don't want you coming in losing too much weight, and often people don't have that. They've already lost some. So eating the right diet, trying to build themselves up through that is always good as well in that pre-transplant period. And also just thinking, the inpatient stays are a long time. So thinking about things that you may want to bring into hospital with you to make it as comfortable as possible. And that can come around to that control. That's a little part that you can control. So each centre will be different in what they allow around things like pillows or, blankets or doonas, those sorts of things. But also a lot of our patients have beautiful photographs, little mementos, all sorts of things that they hang in their rooms to make it sort of, that gives them that inspiration and, refocuses them to be able to, get through the challenging days. So that's all important to bring those things in. Simple questions like, do I have to wear my pajamas all day? Absolutely speak to your coordinator at your local centres. Some people say, I don't want to wear pajamas all day because that makes me feel sick. Fair enough. Don't, some people want to change each night. So making those little things that might be important to you, talk with your coordinators so that can all be worked into what your transplant process is, to give you a little bit of control and make you feel good as you travel, the strongest you can be as you travel through it, because there are going to be some good days and there are going to be some days that you don't feel very happy with the world. So doing what you can to get through those is really important.
Thank you, Annette, for that valuable information. I think it's really always important to look at the holistic side of a person, looking at their physical well-being, mental and emotional well-being, touching on the importance of how we spend time, I think is such a valuable opportunity for us to stop prior to going into transplant and give consideration to how can we spend that time, and what are some things that we can bring in to take us to a place where we can remain calm. And those mediums might be music, they may be, photo books or things that can be washed down. I think that's really important, looking at the holistic person, and certainly movement, keeping ourselves active, and following a good diet. So thanks, Annette, for those valuable little nuggets
Yeah, for
for
sure.
people.
Yeah. And I think Taylor actually highlighted something a little earlier, in and some really helpful advice around that, taking one day at a time.
Yeah,
And
very.
sometimes it sounds a little trite, but actually, when you're receiving large amounts of information and embarking on something um, totally unknown and foreign, um, that is a really good motto to work with, to help manage that overwhelm and to just focus on the things that you do have control over. So a really good piece of advice in focusing on one day at a time.
Taylor also mentioned the value of connecting in, going past the offices, and because
Mhm.
they're just as invested as in you as you are in them. So taking that opportunity to gather your crew to reconnect with those who have given you advice, I think is also an opportunity to feel safe and to feel supported. So I think that too is important advice.